coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one. All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one. All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one. All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one. All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one. All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one.
Good evening. My name is Karen Dodson, Program Director for the All of Us Research Program at the Medical College of Wisconsin. We would like to welcome you to the All of You Health Education session on diabetes. Before we get started, I would like to go over a few housekeeping items. Our presentation today has two parts: disease overview, ask the doctor question and answer session. Please type your questions in the chat box and hold them for the question and answer session. Edwin will be monitoring the chat. This presentation is being recorded. Recording will be available on social media. That will be YouTube, Facebook, Twitter, and Instagram. You have been muted by the host. Please stay on mute unless speaking when we open up the mute chat for discussion. We will do the drawing for $25 at the end of the presentation. At this time, I would like to introduce Melissa. You're muted, Melissa.
Okay, there we go. Hello, everyone. Welcome, and thank you for joining me today. My name is Melissa Rojas. I'm a research program assistant for the All of Us Research Program, and I'll be presenting the first topic of the All of You Education series, which is diabetes. So to start off, I'll give a brief definition of diabetes. As many of you know, diabetes is a disease that occurs when your blood glucose, also called blood sugar, is too high. Blood glucose is your main source of energy and comes from the food you eat. And insulin, a hormone made by the pancreas, helps glucose from food be absorbed into your cells to be used for energy. However, sometimes your body doesn't make enough or any insulin, or just doesn't use insulin very well. So then glucose stays in your blood and doesn't reach your cells. So as you can see on the left side, you can see a normal amount of glucose in the bloodstream, and then on the right, the white spots are excessive glucose in the bloodstream. And now that we've established what diabetes is, we can go into some of the more noticeable symptoms of diabetes. These would include always being tired, hungry. Some of the most common ones are frequent urination, sudden weight loss, blurry vision. It could be numb or tingling hands or feet as well. Wounds that won't heal, always thirsty. Sexual problems, or for women, it could also be vaginal infection. Okay, so expanding on the definition of diabetes, there are actually two types, diabetes type 1 and diabetes type 2. And a common question usually asked is which one of these types is more serious. Both of these types should be taken seriously and are important. However, diabetes type 1 cannot be reversed, and the affected individual must rely on an external source of insulin. And it is interesting because you can see the difference in between the two types of diabetes more clearly. In the diagram for type 1, if we start at the pancreas does not produce enough insulin or any of it, so it causes an increase of glucose in the blood. And so since it does cause an increase of glucose in the blood, the muscle is unable to use it up due to having a low amount of insulin. So glycogen is also a store of carbohydrates that is in your muscle. And since this can't be broken down either, it kind of just stays within the muscle. So this causes ketoacidosis, which is where the body has such high blood sugar that acidic substances called ketones build up at dangerous levels in your body. And I kind of missed my diagram a little bit there. It must be a little bit of a glitch. But I'll give you some more information about type 2 diabetes. It can be similar to type 1 because it can mean that your body doesn't produce enough insulin to maintain normal glucose levels. But diabetes type 2 can also mean that you're insulin resistant. So now that you can see the diagram for if we were to start at the pancreas again, sufficient insulin can be created and secreted into the bloodstream. But if you're insulin resistant, then this still causes an increase of glucose in the bloodstream. But your muscle would be unable to use up the glucose due to the insulin resistance. And this can be due to obesity or just inheritance or other factors leading to that resistance. Okay, and a little bit more information about type 1 diabetes is that it can be that your body, again, does not produce enough insulin or you are insulin resistant. And diabetes type 1 is usually diagnosed in children and young adults, or it typically occurs before the age of 40. And people with type 1 diabetes need to take insulin every day to stay alive. And a little bit more information about diabetes type 1 is that if you have diabetes type 2, your body does not make or use insulin very well, but you can develop type 2 diabetes at any age, even during childhood. However, this type of diabetes occurs most often in middle-aged and older adults, and it's the most common type of diabetes. And then a third type of diabetes is gestational diabetes, and this is, well, diabetes when pregnant. So it develops in some women when they're pregnant. Most of the time, this type of diabetes goes away after the baby is born. However, if you have had gestational diabetes while pregnant, you have a greater chance of developing type 2 diabetes later on in life, or sometimes this diabetes can also actually be type 2 diabetes. So for those who have diabetes, although there is no cure, you can take steps to help manage it and stay healthy. The way to do this is by being informed daily about your health and completing the necessary checkups. So the necessary checkups would be the A1C test, which shows your average blood glucose level over the past 3 months. The higher your A1C number, the higher your blood glucose levels have been during the past 3 months. So high levels of blood glucose can actually harm your heart, blood vessels, kidneys, feet, and eyes. And another type of checkup that can help manage your diabetes would be a blood pressure check. And blood pressure is the force of your blood against the wall of your blood vessels. If your blood pressure gets too high, it makes your heart work too hard. And high blood pressure can cause a heart attack or stroke and damage to your kidneys and eyes. So it's good to keep track of. So going into the other checkups that you can do to help manage your diabetes, this also involves cholesterol checkups. There are 2 types of cholesterol, good and bad. So the bad is actually LDL, or low-density lipoproteins. This is a type of cholesterol that's in yellow there, and it can build up and clog your blood vessels. What you would want would be the one in the green color, which is high-density lipoproteins, which help regulate the low-density lipoproteins and promote their excretion from the body. So it actually helps with blood flow. And another thing you can do to help manage your diabetes would be to stop smoking. Not smoking is especially important for people with diabetes because smoking and diabetes narrow blood vessels, so your heart would work harder to pump blood. So if you do have diabetes, it's important to keep on track. Take your medications as prescribed by your doctor, reach and maintain a healthy weight, add more physical activity to your daily routine, and control your ABCs, A1C, blood pressure, and cholesterol levels, and kick the smoking habit. And now going into ways that can help prevent diabetes. This can again include to stop smoking, making healthier diet decisions, which could mean avoiding or minimizing foods high in sugar and high in saturated and trans fat, avoiding foods with high amounts of salt, controlling portion sizes, and including 30 minutes of aerobic exercise 3 or more days a week, and actually including strength training to build muscle. Because sometimes people call diabetes a touch of sugar or borderline diabetes, and this term suggests that someone doesn't really have diabetes or has a less serious case, but every case is serious and any step that can help you prevent diabetes should be taken. So that concludes our overview presentation, and now we will move on to the Ask the Doc segment with Dr. Jeff Whittle, who is available for any questions about diabetes.
Thanks a lot. As Melissa said, there's both type 1 and type 2 diabetes, and we can take questions about both, although the vast majority of adults will have type 2 diabetes. Just a bit about myself. I have been a general internal medicine doctor working with people with diabetes for close to 30 years now. I see most of my patients at the VA Medical Center, which is pictured on the left, but I also have worked with students and trainees from the Medical College of Wisconsin, which is on the right. As a general medical doctor, I see the diseases that are common in older adults, and in particular, that includes diabetes, high blood pressure, high cholesterol, and people that are having difficulties because of those. It's really nice to talk to people early in the course because, as Melissa explained, there's a lot of things you can do to manage your diabetes. We bring this presentation about diabetes in part because it's likely to be a lot of changes in how diabetes is managed in the near future. Precision medicine, the idea of tailoring medicine to each person's unique biology, environment, behaviors, and genome, is something that's going to affect more and more how people practice. This slide tries to show the difference between the way we practice today, which we call the traditional approach, and the precision medicine approach. So you can see in both categories there's a lot of people and they're very different. Here we show they're different by the different colors. Today, we don't have a lot of way of separating those individuals. So if you go down the traditional approach, we don't typically classify people by their risk, and we don't surveil for diabetes any differently in people, except some very large differences. So if we're a little older, we might look for things, people who are overweight and people from certain ethnic groups. But ethnic groups are a very poor substitute for knowing their genetics. But right now, we just don't know which groups to surveil. So we treat everybody the same and wait for them to get sick. In the precision medicine approach, you can see that we'll separate people by risk. That might include their lifestyle, might include where they live, not just who they are. It also include information about their genetics. Then we can watch for people more easily, and we'll find people before they become symptomatic. So in this picture, we show that people who are likely to become symptomatic are identified earlier, before they become symptomatic, and can begin treatment immediately, if that's appropriate. The next line, the line about treating with, shows the way we do things currently on the left, and that is a single pill is used for each person. So those of you who have diabetes probably started on metformin. That's because that's the best drug on average for people with adult type diabetes. And so most people start with that drug. In the future, what we'll do is we'll look at people uniquely and identify those folks who do very well with metformin, and they'll still continue to get metformin, but there may be other people who do better with a different drug, say liraglutide or Victoza, that's a newer drug, and maybe they are best. And what's really exciting about precision medicine is that by looking at smaller subgroups of people, we may be able to identify drugs that really work well for those folks. So the orange category is something we haven't even invented yet. The bottom of the slide is lost, but you'll find out that then we can then tailor medicine to each individual. So rather than having some people who get, rather than have some people who get metformin do really well, others do only fairly well, and then some people who have a bad reaction to metformin will be more like we are on the right, where everybody gets a drug that's been tailored to their unique individual situation. That situation that we are not there yet, but a lot of research is being done to try to get us to there. And of course, the All of Us research program is one example of the type of research that will get us there. So if we can move on to the next slide, I think it's time for people to offer questions for either Melissa or I to address.
Great. Thank you so much, Dr. Whittle and Melissa, for your comments so far. At this point, if you have any questions, please enter them in your chat room. You may not see the question, but I do, and I'll ask the question on your behalf. So I have a first question here for Dr. Whittle. Are the diabetic pumps just as efficient as a daily insulin shot?
So diabetic pumps are ways of giving people insulin under their skin all of the time. An advantage of the diabetic pump compared to the shots under the skin is that they can vary through the day a little more easily. So somebody who takes a diabetes beta pump may be able to turn their rate of insulin down quite a bit at night when they're not eating and their body's not moving that much. and then turn it up during the day when they are eating calories. So that's a unique advantage of the pump. Pumps do require a fair amount of effort to manage. They have to be kept clean. You have to change the needle that's used to inject the blood under the skin on a regular basis. And so for most people, the pump doesn't really offer any advantage over a well-timed and well-managed set of injections. But for some people, especially people with type 1 diabetes, where it's important that they always have some insulin in their system, the pump can be a really good choice.
Great. Next question. How does diabetes lead to amputations such as toes or legs?
So diabetes, as Melissa said right at the very beginning, attacks several parts of the body. And the ones that come up most often in this area is first, it attacks the blood vessels. And so people you notice that the place that people get amputations most often are the toes and the feet. Well, it turns out that the blood vessels to your toes are the ones that have to be the absolute longest because they create blood all the way from the heart. So there are many, many places where obstructions can happen. So toes and feet are at risk because the blood vessels that get to them have lots of chances to be damaged. The second, one of the other things that Melissa mentioned was nerves. And so as diabetes attacks the nerves of an individual, it makes it the case that it's very hard to feel things that happen to your toes. And so not only do people not feel things like rocks or stones or needles that might penetrate the skin, it also makes it that when you step, your body doesn't balance on the shoes quite as well as it would if you didn't have diabetes. So people with damage to their nerves from diabetes will oftentimes have a slightly deformed foot. That deformity may not enter into their everyday life, but it does put them at higher risk of developing ulcers or other damage to the skin of the foot, and that allows infection to get inside. So the second way that diabetes leads to amputations is it damages the nerves, so people change the way they walk, and it also means they can't feel the early signs of infection. And the third way that diabetes contributes to people losing their feet is that it makes your blood cells that fight infections work less well. So somebody who is unfortunate enough to have those holes in their feet or ulcers develop and then has them become infected can't fight them off as well as somebody who doesn't have diabetes. So both the circulation and the nervous system and the ability of the body to fight infection are damaged by diabetes, which puts them at particularly high risk. I will take the question as an opportunity to reemphasize one of Melissa's points about smoking. And that is that because smoking damages blood vessels, just like diabetes does, people who smoke and have diabetes are at much higher risk of losing their toes or feet or even lower leg to diabetes. This is a late complication of diabetes. One would, as a doctor, would never see this complication happening in the first 15 or 20 years of somebody's life with diabetes, unless they are also smoking, in which case it can happen, unfortunately, very early in the course of their diabetes. So really, quitting smoking is something that somebody with diabetes should make their highest priority. If I had to choose between somebody doing a great job of managing their blood sugar or quitting smoking, I would actually put quitting smoking ahead because it is such a terrible combination of diabetes and smoking.
Okay. Next question. If a child is diagnosed with juvenile diabetes, what are some course of actions a parent can take to ensure a healthier lifestyle as an adult?
That's really a good question. And some of you know that my own son developed diabetes when he was in second grade. And it is a challenge because you want people with kids with diabetes to learn how to manage their own life. And there's a tendency, because they're going to become adults and they're going to be taking care of themselves pretty quickly. There's a tendency for the parents to really try to take over all the management of diabetes. And while that's appropriate for a young child, certainly my child started with this diabetes, it's quite young. But that's very much less the case as kids get older. They need to take more and more of a role. So I think having them learn to ask the doctor questions when they're in the office with the doctor, and oftentimes that makes the doctor much more positive interactions with your child. Having them ask the questions rather than you is a really good strategy. Another thing is to remember that it's not just the diabetes that's the problem. It's also how they eat. So although type 1 diabetes, people that have that are very dependent on insulin, and people tend to think of diet as being as important for type 1 diabetics as type 2. It's also something that's really important for type 1 so they can learn how to eat well. And that oftentimes means the whole family has to change the way they eat. So I think sometimes having a child with type 1 diabetes actually will help the whole family be at lower risk because the whole family will then eat a healthier diet. And then the third is to help them with the struggle of managing sugars. And that is difficult because, especially with type 1 diabetes, frequent blood sugar checks are necessary. And I think the parents can really help the child to, one, have control. The child actually does the fingerprints themselves as much as possible. The child sees the numbers and understands that, oh, well, I'm hoping to be between this range and this range. And the sooner they get that information, the better. So it's really about not so much controlling the child's diabetes while you are taking care of them, because you've only got that child under your care for probably the first 10 or at most 15 years of their life with diabetes. When they're 18 and 25, and my son's now 20, he's 24 now, those kids need to have learned, and if they have come to rely on mom and dad to take care of all of their diabetes, it's going to be really tough when they get out on their own. And then the last thing I'll notice is that when kids are teenagers, those of you who are parents know just how difficult that can be. And one of the big things for teenagers is want to be in control. And it's very hard with diabetes because it seems as though their diabetes controls their life. So the more you can let them have control over some of their choices around managing their diabetes, the better. So I think making sure the child learns to not resent the diabetes, that it's something they live with, not that it doesn't control their life, and then helping them to learn all their lessons.
Okay. And probably the last question here, what are goals regarding blood glucose levels, and how often does one need to check them to prevent from having them too high or too low?
So this is one where I'm going to have to say that they should talk very much with their doctor because the goals for somebody with type 1 diabetes or type 2 diabetes might be very different, as might be the frequency of checking. As Melissa said, type 1 diabetes is really an absolute deficiency of insulin. That person has to take insulin to manage their diabetes well. And because we don't deliver insulin the same way that your body does naturally, we have to check on how your body is using the insulin you administer very frequently. So type 1 diabetics, my child, we used to have to check their blood sugar 6 and 8 times a day. So lots of checks of blood sugar. That's not as necessary in people with type 2 diabetes. In fact, if people with type 2 diabetes manage their diet and their physical activity, many of them can get by with either very few or no blood sugar checks. So maybe having a glucometer available in case they get sick and can't eat normally is really valuable. So they should continue to check it maybe once a week or so to make sure they know how to use the machine and that their scripts are fresh. But really, beyond that may be all the more they need. On the other hand, some people with type 2 diabetes really need to check their sugars almost as often as some with type 1, particularly if they're needing to take insulin on a regular basis and if they tend to have high and low values. In terms of what their target should be, that again is going to be something that the doctor working with you can help. So somebody who has type 1 diabetes, who got it when they were 10 years old, is going to have that elevated level of blood sugar for many years. And you remember I mentioned that I had never seen somebody lose their limbs to diabetes or even a toe that hadn't had it for at least 15 or 20 years. Somebody who's a type 1 diabetic is going to have their diabetes for perhaps 60 or 70 or even 180 years. So that person is going to have a lot longer to develop complications. So the importance of being very tightly controlled is a lot greater. So I might want their blood sugars really never get much above 180, which is would be very difficult for many of those individuals.
Okay, great.
A1C would be in the below 7.
Okay, thank you. I guess we have a couple of the participants that have some questions. Carol, if you have a question, could you unmute and ask your question, please? Carol?
There it is.
There
Okay,
you
wait.
go. Oh, you're muted again.
Okay.
There we go.
Well, I still have this. Okay. Yeah, my doctor said that I was diabetic, after only like 3 months. I had an A1C that was 7, and she gave me 3 months to get it down and told me to diet, et cetera, et cetera. And I did. I went back in 3 months, and it went down to 6.8. Well, she still put me on metformin. And I've been having issues with the metformin. I sweat profusely, and I want to know if I can safely go off of it now, because it also has brought me down, and I get shaky, which I understand is low blood sugar. And I never had that problem before, and I never had any of the symptoms of diabetes.
That's a difficult situation. I don't know if you have any comments you want to make? Or...
Could I hear you?
Dr. Whittle, you're going in and out.
Okay. So I would say that, one, obviously you don't want to have a doctor on the phone diagnose you. You want to have a real doctor diagnose you. So I'll encourage you to go back. And I think it's good that you've identified that you're having problems with the medication. And I think letting the doctor know that is a good idea. I think your degree of control is actually you're doing quite well. I think that what happens is that you sound like you're a pretty young person, and you're likely to still have this diabetes for 20 or 25 years. And so I think that your doctor would like to have you be relatively tightly controlled. And since in general, people with type 2 diabetes, it tends to be a progressive disease. In other words, it gets harder to manage as time goes on. I think that they are aiming to have you fairly well controlled very tightly controlled from the very outset. There are people who really just do better on diet alone at the very beginning, and especially since you were successful bringing your A1C down to 6.8, you might ask if that would be a reasonable option for you. And I think that maybe you could make a deal with the doctor that you'll drop another 5 pounds, or you'll add an extra 15 minutes a day to your physical activity regimen, which would probably improve things even further. So I guess I would say, well, you did do a great job as far as your diabetes, and the fact you're having side effects from that medication is a good reason to go to the doctor and say, hey, that medication is giving me side effects. Either can I try a different one, or it sounds like in your case you prefer to do without entirely, and that's certainly a reasonable request.
Yes, I've upped my physical activity, and I have dropped 57 pounds.
Oh my goodness, that's great.
Thank you, but I'm not young. I'm 69.
Oh, God. See, I'm 69. That's a young one. I'm hoping to get you to be 90 years old, so you can have your diabetes for 20 more years. So in that way, you are young. Again, there are people who are 69 that have all sorts of health problems, and maybe they don't have to manage it quite so tightly. But if you're a healthy 69-year-old woman, your life expectancy is somewhere between 15 and 20 years. And so don't, you can buy all the green bananas you want. You're going to be around for a long time.
Okay. You didn't see me eating that banana, did you?
Thank you so much, Carol.
Okay. Thank you.
Zamira, you have a question? Please unmute and ask your question. You're still muted. There you go.
No, I'm sorry. It was just at the beginning of the meeting when you said that there was issues, and I accidentally typed it in the question box.
Okay, no problem. Thank you.
Thank you. Yep.
Tamara, do you have a question? Please unmute.
Can you guys hear me?
Perfect.
All right. So my question is, what is the average percentage of women developing type 2 diabetes after pregnancy if they had gestational diabetes? Is there a number out there for that?
Well, that's a good question. I think I'd be taking it off the top of my head. I don't know if Melissa came across one in her reading preparing for the talk.
Yes, based on the CDC, this is about 50% actually. So.
Was that 15 or 50, Melissa?
50. So it is pretty high.
All right. Thanks, guys. Appreciate it.
No problem. And the last question, Cassie, do you have a question? Please unmute. You're muted, Cassie.
Oh, I'm sorry. I remuted it.
Okay.
I was just curious if Dr. Whittle had an opinion on microbes in our gut and how they play a role in the development of type 2 diabetes.
Well, I'm definitely in favor of microbes in your gut.
Me too.
Which can't get rid of, which is a good thing since everybody has them. Boy, that's another great topic where a lot of research is being done. This whole microbiome, as it's called, is the next great frontier, and in medicine, I think that right now, because we don't know how to manipulate it, I would say I don't have a lot of guidance on that, but I think almost certainly it will turn out to be the case that your gut microbiome will affect the development of type 2 diabetes. How and which aspects of the microbiome will be important and how it will affect things will vary. Certainly it appears as though microbiome affects weight, and since we know that weight is very tightly linked to developing diabetes, I'm suspicious that microbiome will work primarily through its effect on weight, but it could be a direct effect on metabolism.
Great. Well, I thank you everyone for your questions. If you have further questions, please enter them in your chat. This session has been recorded, and all the questions will be answered when it is posted. So thank you so much for your time, and we'll go on to the next one.
Okay, thank you. Edwin, Dr. Whittle, before we go on, I wanted to ask you a question as far as how research is related to diabetes and how people can benefit from the All of Us research program possibly.
Sure. So I mentioned at the outset that precision medicine is the attempt to find the right treatment for the right person. And that's particularly important in diabetes, where there's about 7 or 8 different kinds of medicine that are a good treatment for diabetes for at least some people. The problem for me as a practicing doctor is, well, when folks come in, I don't know which of those 8 is going to be best for them. Although there are a few clues, they're not very precise. And so we end up using the same drug for most people. That's the metformin I mentioned. Precision medicine and the All of Us research program will help scientists to discover who does what type of people, whether that be a genetic marker or a lifestyle factor or an environmental exposure or perhaps part of the microbiome, is going to do best with which of those medications. I think that similarly, people who don't have diabetes will be able to identify whether or not they are at particularly increased risk. Right now, we can certainly say that as you get older, you're at higher risk, and as you get heavier, you're at higher risk. But there are lots of very heavy older people that I take care of that don't have diabetes, and some young people who are relatively slim that do have diabetes. And so that's because of differences in their genetic makeup, perhaps their microbiome, perhaps other things in their environment that we really don't recognize now, that the All of Us research program will help people to recognize. So it's really important that people participate, particularly those with diseases like diabetes, where there's such a huge genetic component. People don't realize, but with type 2 diabetes, if you're identical twins, so somebody with the same genetic risks that you do has type 2 diabetes, your chance of getting type 2 diabetes is almost 100%. It's very much a genetic disease. It's just that it's a very mixed genetic disease, and we don't know which genes are most important because it's complex. Many genes are important.
Okay, thank you, Dr. Whittle. Dr. Whittle, I know there are different places that people that have additional questions, there are resources available. Can you go through that with us, please?
Sure. You're showing on the slide some of the ones that I think are best. So the American Diabetes Association is a long-time supporter of research in diabetes and also helping people with diabetes to care for their own disease. And that their website has a lot of information about it. Both the Mayo Clinic and the Cleveland Clinic, two well-known medical centers. Obviously, the Mayo Clinic is in Minnesota, and our neighbors, and the Cleveland Clinic is in the city of Cleveland. They have good websites that have information. Typically, if you go to their website, there's a search box, and then you can put questions in about diabetes or a specific diabetes medication. So Carol could type in metformin and get a lot of information about metformin. And those would be, I think, good places to start. I'm hesitant to have people just go to the internet and put diabetes into Google, because what happens then is you get oftentimes not very well vetted information. Whereas the Mayo Clinic and the Cleveland Clinic and the American Diabetes Association, I'm very confident that the information that they give is high quality.
Okay, thank you, Dr. Whittle. Okay, now is the time for the drawing. Okay, I'm going to check the attendee list, the roster that I have, to identify exactly by random who we will select for this drawing of $25. 1 second, please. Okay, it looks like it's going to be, I'll just read your first initial and your last name initial. And then we'll be contacting you within the next 48 hours, and it's M.O. So the person that's M.O., we will be contacting you in the next 48 hours as far as you have won the $25 cash for participating, and we thank you all for participating with us. What I would like for us to do, can you go on to the next slide, please? No, it's going to take us a minute. Sorry. Okay. I wanted to also mention to you that we're going to be having some upcoming sessions, and we are so delighted because we want to thank Dr. Whittle for participating with us today and presenting. We're going to also have other physicians that will be participating with these events that are coming up. So the next one will be prostate cancer. It's going to be September 2nd. We're looking at having those from 6 to 7, so just keep an eye out. We're going to confirm all the times, but that's the time we've been looking at. The next one we're going to be doing is diabetes in Spanish, September 16th, and then sickle cell disease, September 20th. So we want to thank you for taking the time to participate with us and to be a part of this event and this session of information related to diabetes. We also want to hear from you. So after this event, you're going to see where you get an opportunity to complete a short survey. You can do it at this time when you click off and get ready to leave the session, or you can also email us at allofus@mcw.edu for any suggestions that you might have for us or things that you would like for us to talk to you about or concerns that you have related to your health. Next screen, please. So we are located at the Curative Building at the Medical College of Wisconsin, 1000 North 92nd Street, Suite G150, Milwaukee, Wisconsin, 53226. Currently, we aren't taking walk-ins, but you can definitely give us a call. And the phone number is 414-955-2689. You can also, as I mentioned earlier, email us at allofus@mcw.edu, or you can also get in touch with us at allofusmilwaukee and that would be our Facebook page, and you can join allofus.org/Wisconsin. So we would like to thank you for taking the time. We look forward to you joining us for some of the other sessions as well. Everybody have a wonderful day.